dural venous sinuses. Today's topic is dural venous sinuses, and especially about the cavernous sinus we are going to talk in detail. So what are these dural venous sinuses? In the cranium we have got the brain. Covering the brain there is pia mater, that is the innermost. Above the pia mater there is the arachnoid mater. The outermost is the dura mater, and there are two layers of the dura mater. One is the endosteal layer, which is the outermost, which is also called as endocranium, and inside or inside this or below this endosteal layer of dura mater you have got meningeal layer of dura mater. Okay, in between this endosteal and meningeal layer of dura mater there are some spaces which are filled with venous blood and the cerebrospinal fluid. So these are called dural venous sinuses, and sometimes not between the two layers, but because of the reduplication of the meningeal layer itself, there can be a sinus that is present, and which is also called as the dural venous sinus. So these dural venous sinuses, they are grouped into two, that is paired dural venous sinuses, which are present on the right side and left side of the cranial cavity, and the unpaired dural venous sinuses, which are median or central in their position. Okay, so that's how you classify them. Coming to the dural venous sinuses, their walls don't have any muscles, they don't have any valves. Because they don't have any valves, the blood can flow in bidirectional way. They don't have any muscles, they don't have any valves, they are present. That is, the dural venous sinuses are present with a layer of endothelium that is covering, sometimes venous blood and CSF. So it is venous blood along with the CSF that is present in these dural venous sinuses. Now let us first learn the importance of these dural venous sinuses, talking about the applied anatomy, especially for the cavernous sinus, because this cavernous sinus is that sinus that is present in the middle cranial fossa on either side of the body of the sphenoid bone. Now there is sella turcica, where you have got the pituitary gland present in the sella turcica. On either side of the body of the sphenoid you have got the cavernous sinus. Okay, about this cavernous sinus we are going to learn. This cavernous sinus in its lateral wall has got the so many nerves like oculomotor, trochlear, and the ophthalmic and the maxillary nerves. Okay, and in the center of the cavernous sinus you are having the internal carotid artery. Inferolateral to the internal carotid artery there is abducent nerve. The oculomotor nerve, which is the third cranial nerve, and then you have got the trochlear nerve, which is the fourth cranial nerve, and abducent nerve, which is the sixth cranial nerve. These three are supplying the extraocular muscles of the eyeball. So if there is any thrombosis of this cavernous sinus, and why there will be any thrombosis, when you have learnt about the face, there is area called dangerous area of face, and again there is dangerous area of scalp. You remember, the loose areolar tissue of the scalp is called a dangerous area or dangerous layer of scalp. The upper lip, philtrum, ala of the nose, they are forming the dangerous area of the face. Why? That time you have learned there are veins called emissory veins which are connecting these extracranial areas with the cavernous sinus. The infection from this dangerous area of space and loose areolar tissue of the scalp can go into the cavernous sinus. You remember? So the septic foci or the thrombus from these areas, that is from the dangerous area of face or the nasal cavity, okay, or the paranasal air sinuses, if they are neglected, they can travel into the cavernous venous sinus and they cause thrombosis of the cavernous venous sinus. Then how will the patient present? The patient will present with a very interesting feature called ophthalmoplegia. What is that called? Ophthalmoplegia. So what do you mean by ophthalmoplegia? The injury or the infection of these nerves which result in the paralysis of extraocular muscles will result in a condition called ophthalmoplegia. Please look at me. If you want to see to your right, you move your eyes to the right. If you want to see to the left, you move your eyes to the left. If you want to see the roof, you look up and you look down. So there is movement of the eyes possible because of your extraocular muscles, which are supplied by these nerves, the oculomotor, trochlear and abducent nerves. Once these nerves are injured and there is paralysis of extraocular muscles, the person is not able to move his eyeball to the sides. So he will be having only the straight vision. So if the person now wants to look at the right side, he can't move his eyes. So he will turn and then look at the right side. Now if he wants to look that side, that is the left, he is not able to see, he is not able to move his eyeball. Then he will turn and then now he will look at his left side. So what is this called? Ophthalmoplegia, which is making the person to have only the straight vision and not the movements of the eyeball. Are you understanding? This is because of the involvement of the cranial nerves, the third cranial nerve, fourth cranial nerve and sixth cranial nerves which are involved, results in ophthalmoplegia. Then there is severe pain in the region of forehead, severe pain in the region of forehead and eyes, because you see the ophthalmic nerve is having the branches. What are the branches of the ophthalmic nerve? They are lacrimal, frontal and nasociliary. These are the branches of the frontal nerve. So there is edema of the eyelids, there is edema at the root of the nose, edema of the cornea, severe pain in the region of the eye and in the region of forehead. Also there is exophthalmos. What is exophthalmos? Because of the congestion of the orbital veins, there is exophthalmos. Now exophthalmos is a clinical condition. Please see here, where you can see the upper portion of the cornea and the lower portion of the cornea. So this is that exophthalmic look. Are you able to understand? So that's how the patient will have exophthalmos. Please understand, if there is fracture of the base of the skull, and rupture of internal carotid artery, which is a very important constituent of or important content of the cavernous sinus, if there is rupture of that internal carotid artery, it leads to a clinical condition called pulsating exophthalmos. What is that called? Pulsating exophthalmos, where the eyeball is protruded. Okay, the eyeball is protruded and there is exophthalmos. Please understand, it is pulsating. What do you mean by pulsating? You have got, what is the normal pulse rate? 72 times per minute. 72 times your heart is beating. That's what you call the pulse rate. So 72 times your eyeball is also pulsating. You're understanding this forward protrusion with that exophthalmos. How many times? 72 times per minute. That's what it is called, the pulsating exophthalmos. It is a very scary situation. And when you put the bell of the stethoscope over that eyeball, ask the patient to close the eye, and when you put the stethoscope on this eyeball, and then you can hear a loud systolic murmur. You can hear a loud bruit, or a systolic murmur can be heard very well with the stethoscope. Okay, it's a very dicey situation. I have seen only one case in my life and I really got scared, because you feel as if the eyeball will fall out. It's very scary. And again, it will be, in future the patient will be having ophthalmoplegia, where the extraocular muscles, their movement is very much restricted and the person is only having the straight vision. Okay, he has to turn his total body, and then only he can see, or at least he has to turn his complete head. Only by turning the head he can see. He can't move his eyes. At least he has to turn his head and neck. Then only he is able to see the sights. Now, able to understand. So, if there is any problem in these regions, for example, in the region of upper jaw, or if there is maxillary sinusitis that is recurrent, or there are recurrent nasal infections, so you should be very careful. You should immediately go to the doctors for their consultation and take the appropriate treatment, so that this septic foci or emboli will not go to the cavernous sinus, as we have discussed in this first case, the ophthalmoplegia. And this pulsating exophthalmos is because of the basal skull fractures. So, when does the base of the skull gets fractured? Imagine somebody is sleeping and there is collapse of wall on his head or collapse of roof on his head. Sometimes they die, but if they are alive with the rupture of internal carotid artery, yes, they will develop pulsating exophthalmos. Are you understanding? Again, when you are driving a vehicle, so when you are driving a two-wheeler in a high speed without a helmet, and your head had hit the footpath or the pavement, and that also can cause basal skull fracture. Okay, so please do wear helmets when you are going on two-wheelers. Compulsorily you should wear helmets. You can protect yourself and also the families which are dependent upon you. Is that fine? So now we will learn the gross anatomy of the cavernous sinus. We will first learn the names of the paired and unpaired sinuses, and then immediately we will start learning the gross anatomy of the cavernous sinus. Okay. Now let us classify the sinuses. Let us know their names. So they are paired and unpaired dural venous sinuses. So we will learn first the paired dural venous sinuses. They are cavernous venous sinus, the cavernous sinus, then you have got the superior petrosal sinus, then you have got the inferior petrosal sinus, that is the right side and the left side, and then you have got the transverse sinus, then you have got the sigmoid sinus on the right side and left side, then we have got the middle meningeal veins. Some people consider the middle meningeal veins also as sinuses, or middle meningeal sinus you can call. Then you have got the petrosquamous sinus, then other one is the spinoparietal sinus, the paired which I am trying to tell, the spinoparietal, petrosquamous, middle meningeal sinuses, sigmoid, transverse, inferior petrosal, superior petrosal, and the cavernous sinuses. These are paired. Please understand, the transverse sinus and the sigmoid sinus. I repeat, the transverse sinus and the sigmoid sinus, these are called as lateral sinuses by the clinicians, especially the neurologists, the neurosurgeons, the radiologists. They'll be calling the transverse and sigmoid sinuses as the lateral sinus. So you are learning in anatomy, okay? Once you go to the clinical side, you should not tell, I never heard what is lateral sinus. Okay? The transverse and sigmoid sinuses are called lateral sinuses. Then coming to the unpaired sinuses. What are the unpaired sinuses? They are median in position or central in position, whereas the paired are the right side and the left side. Now, what are the unpaired sinuses? The unpaired sinuses are superior sagittal sinus, okay, the inferior sagittal sinus, and you have got the straight sinus, and then you have got the occipital sinus, the straight sinus, the inferior sagittal sinus. Then you have got basilar plexus of veins, the basilar plexus of veins. So you have got what? The superior sagittal, the inferior sagittal, the straight sinus, the occipital sinus, the basilar plexus of veins, and then you have got, so let us count. So here you have got how many? 8 twos are 16 sinuses, okay? 17, 18, 19, 20, 21. In fact, when you are taking the middle meningeal sinuses, you should get 23. So what are the other two sinuses? The straight sinus, the occipital sinus, the anterior and posterior intercavernous sinuses. You have got the anterior and posterior intercavernous sinuses. So this intercavernous sinuses, which are connecting the right and left cavernous sinus. Okay. So some people, they will not include the middle meningeal sinus as the dural venous sinus. That time you will get 21 if you are not including the middle meningeal sinuses. But if you are including the middle meningeal sinus, then you will get 21 plus 2, that will be 23. So there are 23 dural venous sinuses. These are spaces that are present between the two layers of the dura mater, that is outer endosteal and inner meningeal layer. Or sometimes you can also consider where there is reduplication, especially your inferior sagittal sinus. It is because of the reduplication of the meningeal layer itself. The reduplication of meningeal layer itself, which is forming a sinus, and that is the inferior sagittal sinus. Okay. And like that you will be having slight variations, which you should be cautious. Okay. You should verify these things. Then there are no valves. There is no muscle in the wall of the sinuses. There is only a single layer of endothelium. There is both venous blood and CSF that is present here in the sinuses, and there are emissory veins which are opening up in the sinuses. The problem is with the emissory veins. In fact, there is an advantage also. What is the advantage? They maintain the equilibrium of the venous pressures, both intracranial and extracranial cavity. The equilibrium in the venous pressures are maintained. Or sometimes the infection what is there, which is extracranial, can become intracranial. So that is the dangerous part of it. One is good, maintenance of the equilibrium of the venous pressure. Other, what is the bad? The infections which are from the dangerous area of face or the dangerous layer of scalp can become intracranial. They can reach the cavernous sinus. Okay. Now we will go to learn about the cavernous sinus in detail, the gross anatomy of cavernous sinus. Now coming to the cavernous sinus, okay. The cavernous sinus, we are going to learn about its measurements, about its relations, about its contents in the lateral wall, and also the contents present within it, the tributaries and the communications in great detail, okay. I am sure you are with the paper and pen, so you can draw along with me. If you are drawing along with me, things will be very easy. Okay, we said the cavernous sinus is present in between the two layers of the dura mater. Okay, now please look at the board. So here we are trying to draw what? The sphenoidal air sinuses. So these are the sphenoidal air sinuses what we are trying to draw. And here we have got the endosteal layer of the dura mater. So this is the endosteal layer of the dura mater, and this is the sphenoidal air sinuses, okay, what we are trying to draw. And which portion is this? We are trying to draw the sella turcica, the body of the sphenoid, okay. And what is present in the sella turcica? In the region of sella turcica, you have got the pituitary gland which has got its stalk. So this is the pituitary gland with the stalk. Please look here. This is the endosteal layer what I have drawn, and now we are going to draw the meningeal layer which is forming the lateral wall. So this is the lateral wall, this is the roof, and this is the medial wall. Again this is the medial wall, this is the roof, and that is the lateral wall, which is formed by the meningeal layer of dura mater. So the lateral wall, the roof and the medial wall is formed by the meningeal layer of dura mater. Are you able to understand? Now, in the lateral wall of the sinus, you have got the oculomotor nerve, the trochlear nerve, the ophthalmic and the maxillary nerves which are present. And the important content here what you have is the internal carotid artery. Inferolateral to the internal carotid artery, you have got the trochlear nerve. Are you able to understand? So here we are just trying to appreciate the contents which are present in the lateral wall, and now this is the content of the cavernous sinus what we are trying to draw. Okay, the content what we are trying to draw. I hope you are able to appreciate. So this is the internal carotid artery. The internal carotid artery, around it has got the sympathetic plexus of nerves, and this is the abducent nerve. What you are seeing here is the abducent nerve. Now what you are having in the lateral wall? Oculomotor, which is supplying almost all the extraocular muscles of the eye. Okay, and this is the trochlear, which is supplying the superior oblique, SO4. This is abducent, so it is supplying the lateral rectus. You use the LR6, and here it is the ophthalmic nerve which is present in the lateral wall, and this is the maxillary nerve. So if you take this ophthalmic nerve, the ophthalmic nerve is having three divisions. What are they? Frontal, nasociliary and lacrimal. Okay, these are the divisions of this ophthalmic nerve. So within the cavernous sinus, what do you have? You have the venous blood. Okay, the venous blood that is present in the cavernous sinus, there is expulsion of this venous blood that is present in the cavernous sinus by the continuous pulsation of the internal carotid artery, by the gravity, by the movements of the head. So when you are moving your head, and when there is and because of the movements of the head and the pulsations of the internal carotid artery, and because of the gravity, this blood in the venous sinus is expelled out. Are you understanding? Now what is the length of cavernous sinus? Vertically it is 2 centimeters. Vertically it is 2 centimeters, and horizontally it is 1 centimeter. Basically, the interior of the cavernous sinus is divided into many spaces or caverns. They are called by trabeculae. There are many trabeculae which is dividing the space, the interior of the sinus, into caverns or spaces, and that's how it is getting its name, cavernous sinus. So you are calling it as the cavernous sinus because of the number of spaces. It is basically spongy, very soft, you know, the interior of the cavernous sinus. So these are the caverns or the spaces formed because of the many trabeculae that are present. Now anteriorly, if you see, it is extending up to the medial end of superior orbital fissure, and posteriorly to the apex of the petrous temporal bone. If you ask, till where to where is the cavernous sinus extending? Anteriorly it is extending up to the medial end of superior orbital fissure. Posteriorly it is extending up to the apex of the petrous temporal bone. I hope this diagram can make you understand something about the cavernous sinus. Okay, we will keep a part of it and we will rub the other portion. Now coming to the relations of the cavernous sinus. Now what is present medially? Medially you can see there is the pituitary gland and the sphenoidal air sinuses that are present. Medially you have got the pituitary gland and the sphenoidal air sinuses that are present. Now lateral to the cavernous sinus, what do you have? Laterally you have got the uncus of the temporal lobe, which is a part of the cerebral hemisphere. You know, the temporal lobe is a part of cerebral hemisphere. Uncus of the temporal lobe of the cerebral hemisphere is present laterally. Now what is present superiorly and inferiorly. Superiorly, if you observe, now you have got the optic tract and the optic chiasma. So here you are having the optic tract and the optic chiasma. You also have the carotid artery, internal carotid artery is there, and then you have got anterior perforated substance. So superiorly what you are having? You are having the optic tract, you are having the optic chiasma, you are having the internal carotid artery, and then you are having the anterior perforated substance. Now what do you have inferiorly? Inferiorly you have got the foramen lacerum that is present between the body and the greater wing of the sphenoid bone. So inferiorly you are having the foramen lacerum, and this foramen lacerum, where is it present? Between the junction of the body and the greater part of the sphenoid bone. Then after the superior and inferior relations, medial and lateral relations, let us go with the anterior and posterior relations of the cavernous sinus. Now anteriorly it is going up to the level of superior orbital fissure, and posteriorly up to the level of apex of petrous temporal bone. Posteriorly it is going up to the level of apex of the petrous temporal bone. Here you will get the crus cerebri of the midbrain also. The crus cerebri of the midbrain you are getting posteriorly. And here laterally you have got the foramen lacerum, also you have got cavum trigeminale. You are having cavum trigeminale here, that is present laterally. Okay. So these are the relations of the cavernous sinus. Okay. So we have finished medial, then lateral, then anterior, posterior, superior, inferior. Okay. Now we will go with the tributaries of the cavernous sinus. Now what are the tributaries of cavernous sinus? If they are asking you, the tributaries are coming from the orbit, they are coming from the meninges, also from the brain. So there are three sources basically. Now from the orbit, you know, there are superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. So what are the tributaries from the orbit? The tributaries from the orbit are three in number: superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. And from the meninges, what do you have? The frontal trunk of middle meningeal vein. Okay, the frontal trunk of the middle meningeal vein and sphenoparietal sinus. The sphenoparietal sinus and the frontal trunk of the middle meningeal vein. These are coming from the meninges, the tributaries. And what are the tributaries from the brain? From the brain you have got the superficial middle cerebral veins and inferior cerebral veins. So you are having the superficial middle cerebral veins, superficial middle cerebral veins, that is coming from the brain, and then you have got the inferior cerebral veins. Okay, so these are coming from the brain. So you have got from the orbit, from the meninges, and from the brain the tributaries which are getting the venous blood, the tributaries of the cavernous sinus. Okay, then coming to the communications. So we will now go with the communications of the cavernous sinus. So please draw this diagram along with me. It will be very easy for you if you are drawing along with me. Okay, so first let us go with this. Now what is that I am drawing? I am drawing the cavernous sinus. So these are the right and left cavernary sinuses which I am trying to draw or present on either side of body of the sphenoid. Then we will have to go with the tributaries of the cavernous sinus. So this is the superior ophthalmic vein, the inferior ophthalmic vein, the central vein of retina. The superior ophthalmic vein, the inferior ophthalmic vein, and the central vein of retina. from the orbit. Then you have got the sphenoparietal sinus and the middle meningeal veins. The sphenoparietal sinus and the middle meningeal veins, which are coming from the meninges. Then you have got the superficial middle cerebral veins, then the inferior cerebral veins. The inferior cerebral veins, these two small ones are the inferior cerebral veins, and the large one is superficial middle cerebral vein. Are you able to follow? Also you have got some emissory veins. These are the emissory veins which are coming out of the foramen, or which are passing through the emissory veins, which are passing through the foramen lacerum, foramen ovale, and the small foramen which are present at the base of the skull, that's the sphenoid foramen. So from here you have got, that is from these foramens you have got the emissory, veins, okay, which are coming from the foramen lacerum, foramen rotundum, and the sphenoid foramen, those foramen which are present at the base of the skull, these emissory veins. And here you see you have got a large foramen of the skull, that is the foramen magnum. Now here you have got the jugular foramen. Here from the superior sagittal sinus, here you have got the transverse sinuses, and here this is the sigmoid sinus. Now here this is the transverse sinus, okay, and here it is the sigmoid sinus. This is the superior sagittal sinus, okay. Now there is superior petrosal sinus. This is the superior petrosal sinus, which is communicating with the transverse sinus. There is superior petrosal sinus, which is communicating the cavernous sinus with the transverse sinus, and this is the inferior sagittal sinus, which is communicating the inferior petrosal sinus, which is communicating with the internal jugular vein. Here we have got the internal jugular vein, that is the jugular foramen. So these two are the jugular foramen that are present. This is the foramen magnum, okay. Here if you see on the other side, you have got the transverse sinus, and the transverse sinus, now it will become the sigmoid sinus, and here you have got the straight sinus. So here this is the straight sinus, this is the transverse sinus, and this is your sigmoid sinus. So this one will be the sigmoid sinus. Here on the other side also, this is the superior petrosal vein which is communicating with the transverse sinus, the inferior petrosal vein which is communicating with the internal jugular vein, okay, that is present in the jugular foramen. And here you have got the basilar venous plexus. This basilar venous plexus, they are communicating with the internal vertebral venous plexus. This is your basilar plexus of veins which is connecting with the internal vertebral venous plexus. The cavernous sinus of the right side is connected with the cavernous sinus of the left side by anterior intercavernous sinus, posterior intercavernous sinus. Are you able to appreciate the diagram of the communications of the cavernous sinus? Okay, so here you have got the superior petrosal sinus communicating with the transverse sinus, the inferior petrosal sinus communicating with the internal jugular vein that is present in the jugular foramen. There are basivertebral venous plexus that are communicating with the internal vertebral plexus of the veins. Okay, we have got some emissory veins from the foramen lacerum and the foramen rotundum, from the foramen rotundum and from the foramen ovale. There are some emissory veins which are entering, and the blood in the emissory veins, they are passing in both directions because they are the valveless veins. So these are communicating with the cavernous sinus, and pterygoid venous plexus of veins. This is very important. The dangerous area of the face. It is opening into the pterygoid venous plexus, and from the pterygoid venous plexus you have got the emissory veins which are opening into the cavernous venous sinus. Okay, so you can also write one emissory vein with the pterygoid venous plexus. Pterygoid venous plexus. Are you able to follow what I have drawn? The diagram on the board, the pterygoid venous plexus. It is connected to the cavernous sinus is communicating with the pterygoid venous plexus via the emissory veins that are present. Okay, it's not foramen lacerum. Sorry, the emissory vein is not passing through foramen lacerum. Emissory vein is passing through foramen rotundum, foramen ovale, okay, and also this pterygoid venous plexus. Is that fine? Thank you. Let us quickly revise the cavernous sinus. So if you see the cavernous sinus name is derived because of the caverns that are present, or nothing but the spaces which are present in its cavity by the trabeculae. It is 2 centimeter in its length, 1 centimeter in its width. It is having a lateral wall, roof and a medial wall that are all formed by the meningeal layer, whereas the floor of the cavernous sinus is formed by the endosteal layer. Coming to its extent, anteriorly it is extending up to the medial end of the superior orbital fissure, posteriorly up to the apex of the petrous temporal bone. If you see the relations, medially it is related with the pituitary gland and the sphenoidal air sinuses, laterally with the uncus of the temporal lobe of the cerebral hemisphere of that side. Then if you take superiorly and inferiorly, what are its relations? Superiorly optic chiasma, optic tract, internal carotid artery and anterior perforated substance. Inferiorly you have got the foramen lacerum. Inferiorly you have got the foramen lacerum which is present between the body and the greater wing of the sphenoid bone. Okay, and if you see anteriorly, it is not inferiorly cavum trigeminal, it is laterally. Here it is laterally, it is the bonded by the uncus of the temporal lobe and cavum trigeminal. The cavum trigeminal. Okay, cavum trigeminal. Now you know the trigeminal ganglion is present in the cavum trigeminal. The trigeminal ganglion is present, and then you have got the other name for cavum trigeminal is Meckel's cave. Okay, it's a short note, and we have made a video on that. You can see that also if you want to learn more. And then coming anteriorly, you have got the superior orbital fissure, and posteriorly we have got apex of the petrous temporal bone and the crus cerebri of the midbrain. Anteriorly you can also add apex of the orbit. Anteriorly you can add apex of the orbit and superior orbital fissure, and posteriorly it is apex of the petrous temporal bone and the crus cerebri. Okay, these are the relations of the cavernous sinus. Coming to the tributaries, both from the orbit, meninges and brain, it has its separate tributaries. From the orbit, it is the superior inferior ophthalmic veins with the central retinal vein or central vein of retina. And coming from the meninges, it is the middle meningeal veins or the sphenoparietal sinuses which are draining as the tributaries of the cavernous sinus. And coming from the brain, it is the superficial middle cerebral vein and the inferior cerebral vein. Please understand, the superficial middle cerebral vein drains into the superior sagittal sinus. This superficial middle cerebral vein is draining into the superior sagittal sinus. Okay, this is just a engineering diagram, this line diagrams. Okay, so just for you to understand what exactly is the pattern of communication. This diagram is the different communications of the cavernous sinus. And applied anatomy, pulsating exophthalmos, ophthalmoplegia. These are very specific in case of embolus, the septic thrombus of the cavernous sinus. So the infective emboli, they go into the cavernous sinus via the emissory veins from the dangerous area of face and scalp, and then they cause ophthalmoplegia. Also there is exophthalmos in case of this because of the congestion of orbital veins. Exophthalmos in case of thrombosis of the cavernous sinus happens because of congestion of the orbital veins. congestion of the orbital veins, they cause exophthalmos. Okay, and there is a pain in the region of forehead and eye because of the distribution of the ophthalmic nerve. Ophthalmoplegia, paralysis of the extraocular muscles as their nerves are paralyzed. Pulsating exophthalmos because of rupture of internal carotid artery and mixing of the arterial and venous blood, which will cause the pulsating exophthalmos. Thank you.